Welcome to OSNHA's June Education Session. I'm Laurel Smith, an OSNHA Board Director and Chair of the Education Committee. Thank you for joining us today. A couple of announcements. Just a reminder about our August 25th conference. The Eventbrite registration page is ready to go, and you can get the link from our website homepage. We hope to see you there. During our session today, you will all be muted to avoid noise disruptions. We will have Q&A session at the end of the main presentation. You can send your questions at any time using the Zoom chat function, or hold them until we open up for Q&A, at which time we will unmute everyone. We are recording this session and it will be posted on our website for future reference. First of all, I'd like to introduce you to Kelly McNall. Kelly is a reverse mortgage specialist with OneTrust Home Loans, one of our newest associate members. Kelly, thank you for stepping up last minute and being here with us today.
You are very welcome.
The floor is yours. Please share with us.
Thank you. So my name is Kelly McNall. I'm a reverse mortgage loan officer, and I've been doing it for 8 years. We feel like this is the most misunderstood and underutilized asset for seniors in this market, particularly for facing issues like in-home care and aging in place. So do you want me to share my screen and just kind of work through it real quick? Let's see. All right, you got it?
Yes, we do.
All right, great. So anyway, what I was saying is serving up knowledge. So unlocking a commonly misunderstood and underutilized asset. A lot of people, there's trillions and trillions of dollars in home equity owned by seniors, but they don't have access to it. Typically, your home is your biggest source of equity in all of your retirement savings. And if you don't have access to that asset, it's basically just a house. And you'll find, especially as you get older, you have a lot more equity in your home. And when that remains untapped and you run into any kind of health concerns or problems or wanting to age in place, this can be a really good source for people to be able to do that and to afford doing that. A lot of retirement concerns. 88% of seniors prefer to age in place at home. I think it's even more now post-COVID. I believe that's an old kind of, percentage rate. Post-COVID, people just really don't want to be in a retirement. They want to age in place. They want to remain in their home. I just told you I spent a week with my mom in Maine. I can't get her to move here. She wants to be in her own home, and that's where she wants to live for the rest of her life. More retirement concerns are longevity, hoping that we don't run out of money. So aging in place and having that home care can be something that can really trigger them running out of money. Lifestyle, again, if you want to age in place and not have to worry about money as much or being able to take care of your health at home. Liquidity, again, having those liquid assets for those types of emergencies and unforeseen events. And then legacy. A lot of people want to keep a little bit of money or something for their children, and hopefully they can do that by utilizing a reverse mortgage. Typically, the ways that you access home equity would be a cash out refi, in which case you'd still have a monthly mortgage payment, a home equity line of credit, in which case you'd still have a mortgage payment, a reverse mortgage, optional mortgage payments, they're not mandatory. And then you could sell your home. Again, that's a big concern, especially in this market. You sell your home, where are you going to go? A home equity conversion mortgage, more commonly known as a reverse mortgage, is an FHA insured non-recourse loan on a primary residence for borrowers over 62. Non-recourse means they'll never owe more than their home is worth. What it can do is eliminate monthly mortgage payments. So if there is a mortgage payment in place, a lot of times we can refinance that mortgage into reverse, eliminate monthly mortgage payments, increase cash flow. Access home equity in multiple ways with payments made to you monthly, lump sum, or combination, or having a nice standby line of credit. The loan does not become due until the last borrower leaves the home, and they have it for at least 12 months. So when they leave their home permanently, there's up to 12 months to go ahead and satisfy that mortgage, just like you would in a traditional mortgage today, only we give a lot more time. Loan proceeds are not taxable. That's kind of a big deal these days. And the line of credit that we access to them does grow over time. The homeowner will continue to occupy as their primary residence and remain title on the home. We don't keep the home, it's their home. We're just a mortgage holder. They pay their property taxes, homeowners, HOA, any maintenance on the property. And those are the big sticker things. Main thing to consider is that with reverse mortgage, it's a mortgage that can access equity into your home, but the mortgage payments are not mandatory. I'll be honest with you, most of my clients aren't making mortgage payments. They can, but most of them are not, because that's why they're in a reverse mortgage. This is one of my favorite quotes. The best way to take care of your kids in the future is to make sure they don't have to take care of you. We talked about, oh, is it clicking on your screen okay? Retirees on average have over 70% of their net worth left in home equity. A reverse mortgage can access that equity for costs like in-home care and aging in place. Most health events happen at around age 75 and they last about 4 years. And well, you guys are the experts on what the cost that can be to keep somebody in the home safely with a good caregiver. And the strategic use, this is just like a quick little overview, asset strategy, but the big thing that we're concentrating today on is in-home care, funding or supplementing in-home care and paying for those costs associated with having those caregivers come to their home. And then a lot of this other stuff really doesn't relate to today, but it's things that we can use. And what I would encourage, these are the fundamentals, how much equity, how much money we lend depends on age, interest rates, and home value. So the older they are, the more we lend. Lower the interest rates, the more we lend, and the higher the home value is, the more we lend. The interest rates are volatile right now, but they're not as bad. For my career, I've been averaging just over 5%, 5.5%. Right now, I can get most of my clients into just over 6%. So it's not as, for me anyway, it's not as catastrophic as most people think. How can they access the equity? We can do monthly lifetime payments, term payments that can last a term of any time that they want, how they want to strategically set that up. It could be 1 year, 5 year, 10 years. Then of course, a revolving line of credit where they have access to the money as they see fit. They take it when they need it for whatever they think they need it for. And then main thing that I want to do is 90% of my job and what I do is education. This is really just a unicorn. A lot of people don't understand the product, don't understand how it works. They've got all these myths and ideologies about the product that it's just not, it's not a mortgage. We want their house. We're going to keep their house. This is an FHA federally insured loan. It's a HUD product. We pretty much just put it into place for them and it's insured by the government. So we're under a lot of stipulations and regulations that can take care of this and protect the consumer. And there's a lot of consumer safeguards in place. So I was just saying, hey, listen, let's just try and set up a one-to-one, whether it's on Zoom or have coffee, get together and just talk about your business, talk about my business, see how we can help each other and educate each other on how we can help each other grow our business. I really do like to educate in community environments as well, lunch and learns, happy hour seminars. So if anybody wants to invite me in or you want to be involved with anything that I do, I would so invite that. And again, if we schedule one-to-one, we can work on those things together. My contact information is here. That's my cell phone. Feel free to call me at any time. I'm happy to be there for anything that you might need. And that's it. Thank you.
Kelly, I've got a question.
Yes, ma'am.
Years ago, when reverse mortgages were really big, there was required education for anyone wanting to participate. Is that still there?
Yes, very good question. So HUD requires that anybody that's going to apply for a reverse mortgage loan attends a counseling session with a HUD counselor, and that's a consumer safeguard. So essentially, they'll have the same information that I provide for them. The counselor will talk to them to make sure that they understand the difference between the various loan products, what they're using it for, that nobody coerced them, that they understand what they're getting into. They cannot move forward until they pass that counseling session. So it's a very big, huge, positive consumer safeguard for consumers that we have in place today.
Great, thank you.
You're welcome.
Thank you, Kelly.
You're welcome.
Remember to stop sharing your screen for us. I appreciate that.
Yeah, I know it's Zoom. I'm sorry.
Okay, that's all right.
Okay.
I don't see any questions in the chat. Does anyone have any questions? You can raise your hand and we'll go around and look. Linda, do you see any?
Nope,
Okay.
I think you're okay.
Okay, thank you very much, Kelly. We certainly appreciate it. And again, for stepping up last minute. And Kelly will be at our conference on August 25th. So make sure you stop by and visit with her at that time.
Awesome.
Okay, today our featured speaker is Robert Espinoza. He's the Executive Vice President of Policy with PHI, where he oversees its National Advocacy and Public Education Division on the direct care workforce. Today's subject is how financial insecurity among the caregiver workforce affects all of our businesses and what can be done about it. Please, Robert, enlighten us.
Thank you, Laurel, and Good morning or good afternoon, everyone. It's good to see all of you, and thank you for the opportunity to speak today about this critical issue of recruiting and retaining direct care workers and what we can learn as a sector, and also what kinds of questions we should be asking to make sure that we both create good jobs, but also stabilize a really critical sector. I'm just going to take a moment to share my screen. Give me 1 second. There we go. So by way of introduction, I am Robert Espinoza, and I oversee PHI's advocacy and public education work on the direct care workforce. And so I've been here for a little over 8 years. And I should say, because I'm presenting to an Arizona audience, that I actually grew up in the Southwest. I grew up in Pueblo, Colorado. So even though I live in the Northeast, in New Jersey and in New York, I have a real affinity towards the Southwest and sort of the challenges that many states in that area are dealing with. For those of you who are not familiar with PHI, we are a national organization that focuses on strengthening the direct care workforce. And so I'm going to start this presentation by just doing a little bit of level setting, describing who these workers are, what are some of the challenges that they're facing. I'm going to share then one of the biggest challenges that we see is often what they wrestle with in terms of poverty and living in these low-wage jobs, working in these low-wage jobs. I'm then going to share what we consider to be a quality job framework for direct care, which is really intended for anyone who's employing workers or engaging them in other ways to think about what are all the elements that we can institute to ensure that these jobs are high quality and that workers would want to take them jobs and also stay in them. So I'll open it up to conversation at the end, but I hope it to be a really robust conversation about these workers. Just to start, by definition, direct care workers are workers who support older adults and people with disabilities in a wide range of long-term care settings. They work in people's private homes, they work in residential care settings like assisted living and many other places, and they also work in nursing homes. We estimate that because there are currently about 4.7 million direct care workers, 2.6 who work in home care, and the rest work in congregate care settings. Because these jobs, because so many workers leave these jobs often for other sectors, and because a percentage of these workers are actually leaving or retiring from this workforce, we estimate that between 2019 and 2029, the direct care sector will need to fill about 7.9 million jobs in direct care. And that's a sizable number when you consider how many job openings there are already, but also just the growing demand that we're seeing. Well, our research also shows that the median hourly wage for direct care workers is around $14 an hour, and that varies by state, and sometimes that varies by employer as well. Because many workers are relegated to part-time work, either by their employers or by the economy, they make about $21,000 a year, which means that about half of this workforce makes less than that. About 40% of workers live in or near poverty, and I'm going to describe in a few minutes what it means to live in poverty when you're a worker. And because there's no reliable national or even statewide estimate on turnover rates in direct care workers, we are really relying on individual studies to get a sense of how often do these workers last in these jobs? And the turnover rate is about 60 to 99%. Oftentimes, these workers leave within the first 90 days. So we are seeing incredible turnover, incredible churn. It affects these workers financially, but it affects employers, of course, because when you hire a new worker, you then have to retrain them, et cetera. And it affects the consumer, the older adult and the person with disability, because they're not getting that continuity of care. So it is something that's affecting them dramatically. A few years ago, we did a study to look at the median wage for direct care workers compared to other occupations with similar entry-level requirements. And what we found is that in no state, nor in DC, was the median wage for direct care worker equivalent or higher than those other occupations, meaning that in all 50 states plus DC, janitors, retail salespeople, and customer service reps were actually making a higher wage than direct care workers. And this is a bit of a startling statistic. When you looked at occupations, by the way, that had lower entry-level requirements, what we saw was that only in 26 states was the direct care worker median wage higher than those jobs. So this means that if you're an employer or you're a consumer hiring a worker directly, you are competing with companies like McDonald's and Macy's and so many others for candidates from the same labor pool. And if those companies can offer higher wages, plus more stable schedules, signing bonuses, and potentially less dangerous jobs, so to speak, or less grueling jobs, it's going to be hard to really recruit workers at this stage. And so what does that mean for us as a sector? It means, of course, we should be offering higher wages, but it also means that we should be thinking about all the other ways in which jobs can be better. In this sense, I just want to pause and talk about the difference between a living wage, a competitive wage, and a commensurate wage. So typically the debate around wages focuses more on a living wage, that we should make sure that the wage is accounting for what a worker needs to make based on a local cost of living. And that's going to vary by jurisdiction. It's going to vary by zip code, by county, etc. A competitive wage says it should probably be even higher than that, because companies like McDonald's or Macy's, etc., are probably offering workers a higher wage than even the living wage in that area. But then if we were to take a step back and say, if we were to transform these jobs, truly professionalize them, what should these workers be making at that level? So a real world example, a living wage in a certain area might be $15 an hour. A competitive wage might be closer to $20 an hour, and a commensurate wage, if we really professionalize this job and offered advanced roles and so much more, might be closer to $30 an hour. Now, many of you might be balking out those numbers already, saying, well, we're not even close to a living wage. And yet that's the reality in which we're living, right? That if we are going to effectively recruit and retain workers on compensation alone, we need to be thinking more in the competitive to commensurate wage range. During the pandemic, in the first 2 years, we saw that we examined the extent to which states passed both hazard pay policies and sick leave policies. This was a time, as many of you remember, where a lot of workers were leaving the sector. Of course, the COVID-19 pandemic in particular targeted nursing homes and people with serious chronic conditions, etc. And so we wanted to get a sense, like, to what extent were states offering policies that would increase their pay, at least temporarily, and sick leave policies so that if a worker became sick or one of their family members became sick, they were able to take time off. This map shows that not many states did. These were the states that either offered a single hazard pay policy or more than one hazard pay policy, and some of these were already in place prior to the pandemic. And they typically didn't last more than a few months. In fact, once the early few months of the pandemic, once we got past those first few months, most of these hazard policies went away. Paid sick leave policies were similar, although many of them already had them in place. And you can see in the legend that it varied. Arizona had an existing paid sick leave policy before the pandemic emerged. But again, once the first few months ended, many of these policies went away. And as the emergency order lifts, we're seeing that most of them are going away as well.
Robert,
yes.
I hate to interrupt you. I don't know if it's just my screen
Oh.
or if it's others, but I see the map on the upper left and then the next slide that's going to come up, and then there's a black area down below and no notes down on the right. So I might
be sharing.
It looks like your presentation, forum, if you would, Robert, that we're looking at, rather than
just the whole individual slide on the screen at once.
Oh, let me
single screen.
Just make it full. Just make it full screen, Robert.
Let me just see how to do that.
You go up to display settings at the very top.
Okay.
It should allow you to swap presenter view and slide view.
Oh, did that do it?
Yep.
Yeah, beautiful.
Oh, thank you. And thank you so much for telling me.
100%.
My apologies. So the other challenge that we see often is limited training and advancement opportunities. What we see is a few things. One is that very often the training standards that are in place for direct care workers, they vary by state, they vary by occupation, and they vary by setting, meaning that it's a fractured, scattered system, and that if you're trained in one setting or by one employer, it doesn't necessarily mean that you can work in other settings, and it certainly doesn't mean that you can work in other states. And so that creates kind of a problem in terms of how versatile the workforce is. Now, if you're a home health aide and a nursing assistant, you're required by federal law to undergo at least 75 hours of training. And if you're a personal care aide, there are no federal training standards and no state goes past 40 hours. So it's a way in which a lack of training harms the worker, of course, because they're not necessarily getting the type of training approach that they should be getting. But if you're a consumer, it means that you probably can't be assured that if you hire a worker, if you are an agency that has a worker, that they've necessarily been trained in the right skills. That's something that becomes employer to employer and state to state. Also, what we're seeing is that the type of people that many direct care workers are supporting, older adults and people with disabilities, that it's a clientele that's become increasingly complex and diverse. But in complexity, it means that we're seeing higher rates of dementia, higher rates of cardiovascular disease and diabetes. We're seeing kind of new conditions emerge, for example, long COVID, or a generation of people aging with HIV and AIDS is another example. And all of this requires specialty training. It requires a specific set of skills and knowledge. And yet, many training programs and requirements don't often account for that diversity. Also, when you look more closely at the programs that are being used to train workers, what we often see is that they're didactic in nature, meaning that they're in nature of what you're seeing right now. It's a classroom style approach. A person is speaking at them. It's often what you see in universities and so on. And yet it's not often the approach that works best with adult learners, especially if education levels are lower. And that's the kind of candidate pool that we often see. And so it's not accounting for those adult learners and learner styles that we often need to really acquire the kinds of skills and knowledge for these roles. And we see very limited opportunities for advancement. In fact, when advancement is discussed in this sector, it's often discussed as moving out of direct care into LPN positions, for example, which of course will only ever reach a certain percentage, or into administrative and management positions. But that doesn't really keep workers within direct care, which is where we're seeing the staffing crisis. So potentially there's a need for advancement that would keep workers within direct care into roles like dementia trust specialist, or a care transition specialist, somebody who helps somebody come from a hospital and transition into the home or into a rehab center, as one example. Again, I mentioned that there isn't really great data on turnover rates, but two recent studies showed that the turnover rate for home care workers is at 64%, and for nursing home staff is at 99%. And again, they tend to be competing with retail and fast food. I want to pause for a moment to talk about what does poverty look like for direct care workers, because this is one of the overarching challenges that we're seeing for these workers. It affects them individually and it affects their families because poverty is a crushing reality, but it's also one of the primary reasons that many workers leave these roles for jobs that can pay a little bit more. So just for definitional purposes, in the US, poverty is defined by comparing what a person or a family makes to a set poverty threshold. And then, of course, what's needed to cover basic needs. And so anybody who falls under that threshold are considered poor. Now, this is a mathematical calculation. And so, of course, there's going to be people who don't fall within that, who are nevertheless living in or near poverty and are experiencing the same kind of experience of what it means to be impoverished. There have also been opportunities or efforts to expand that definition. And so in 2016, we began measuring what is called the OPM national poverty rate. And what it calculated was that around 12.7% of the US was in poverty, and that accounted for about 40.6 million people. And so, of course, that's an understatement when we can think about broadening that definition. There are probably many more people that are living in poverty, but we should also think of poverty as something that's cyclical. So there are a percentage of people who are occasionally poor. This means that a situation occurs that throws them into poverty. Maybe they acquire a medical debt that they need to pay off for a few months or a few years, and so they fall into poverty for that reason. Cyclically poor are people who go up and down, in and out of poverty. These might be, for example, farmers who rely on making money within a certain season, but then the rest of the year they don't make as much and they fall into poverty. Usually poor are people who are almost always poor, and there might be an incident, maybe they receive, an earned income tax credit during tax season, and that pushes them out of poverty for a few months. But for the most part, they're actually in poverty most of the year. And there are people who are always poor, and these are people who are struggling with poverty, sometimes, usually since they were born and across generations, but it's something that's really persistent. This is an image that you'll find quite a bit online or in a lot of discussions about poverty, which is to say that poverty is often a cycle. So a child is born into poverty. They then experience disadvantaged education and skills. Maybe they're living in neighborhoods or with school districts that have just fewer resources, which then means they then struggle to get a job. They fail to escape the poverty cycle, and then they grow a family that is in poverty, and you see how that cycle goes in and out. And so when we think about interventions, we should think about what are the interventions that are targeting people in different aspects of this cycle to disrupt the cycle of poverty for people, and how do we think about that? In direct care, this is a simulation that assumes, let's say you make $10 an hour and you work 40 hours a week. Many workers are not afforded 40 hours a week, but let's say they're doing that. You would see a gross pay of about $1,600, take out taxes, and about $1,200. When you account for all of the expenses that they might be making, that they might be accountable for, it quickly gets eaten up by housing, by utilities, food and transportation. Debt repayment is an enormous expense for many low-income and middle-income people. Clothing, childcare, their own elder care or home care needs, as well as entertainment, medical expenses, etc. You can then see that the picture shows how hard it is to make $1,200 a month, how hard it is to stretch it and to make sure that everything is being paid for, much less to save. This is a map that was produced by the National Low-Income Senior Housing Coalition. And what it shows is the number of hours at minimum wage that are needed to afford a one-bedroom rental home at fair market rent. And what you see is that the darker that the map is, the more hours that are needed. And so you can see a few areas where it's light, but in no areas is it really white, right? Which meaning that you need at least to work a certain number of hours, 40 hours at minimum wage to afford a one bedroom. And what it does is it means that many people in poverty are often living in studio apartments, they're living in multi-family homes, or we're seeing a growth in homelessness. And homelessness is also a cyclical, sometimes in and out kind of experience. Poverty is also something that goes in and out. This is the map, by the way, that shows more closely what that looks like. And you can zoom in on what that looks like for Arizona. If you go on the website for this organization, you can see by county or by zip code. But it also means that there's a link between poverty and poor health. So if you're poor, you can also experience decreased life expectancy, lifelong illness like cardiac illness and diabetes, poor nutrition, depression, and so much more. And it goes both ways. If you're in poor health, that also hurts your employment, which then amplifies poverty. So you can see the kind of the inescapable and often kind of magnitude of poverty on poor health and on workers who are working in many ways important and yet grueling hours. I want to shift for now to a conversation about job quality. So much of this is what can we do as employers, as individuals, as other kind of entities within the long-term care system to really make sure that workers have good jobs that address the poverty that I just discussed, but that also make sure that we have a stable workforce that can provide the optimal care that older adults and people with disabilities deserve. At PHI, we base both our policy interventions and our workforce interventions on a framework of job quality. It's available on our website. It's called the 5 Pillars of Direct Care Job Quality, and I'm going to guide us through those 5 pillars. It also includes about 29 strategies within those 5 pillars, and I'm going to talk about each of those with some concrete examples. The 5 pillars broadly include quality training, fair compensation, quality supervision and support, respect and recognition, and real opportunity. And again, there are 29 strategies that span these 5 pillars, and I'm going to talk about them individually. I want to start with this quote that comes from a guide that we produced in 2018. The quote says, "As with all employees, direct care staff need opportunities to learn and grow in their jobs. Otherwise, they will start looking elsewhere for new challenges. By offering specialty training and advancement opportunities, you can maximize a worker's contribution, reward their dedication, and improve retention in the long run." Now, that's a lofty statement and goal, and I'm going to talk through, like, what does that mean piece by piece? The first pillar that I want to discuss is quality training. There are a few different dimensions to this, and I'll share a few examples. One is making sure that training is accessible, that it's affordable, and that it's relevant to the actual job. Too often we see that workers are asked to pay for their training in order to enter the sector. And what that means is if you're a low-wage worker and you're wrestling with the slide that I just showed, $1,200 a month with all those expenses, and then you're required on top of that to pay for even a low-cost training, you're going to lose a percentage of workers. Now, maybe the math of it is such that you have to charge for the training, but I just want to say that affordable training is an important piece to making sure that workers take these jobs and that they stay in these jobs. Accessible can mean a lot of things. It means that if you're doing an in-person training, that a worker isn't required necessarily to drive or travel more than a certain number of miles or a certain number of hours. We've seen, for example, a training program in a certain state where a worker has to drive like an hour and a half to 2 hours. Well, you're going to lose a lot of workers in that regard. It may be also that within a big city, you have to drive, say, 45 minutes to an hour. That could also create a problem when every hour matters for a low-wage worker. Increasingly, we're seeing that training is being offered online. It's either entirely online or it's a hybrid training where some of it's in person, but a lot of it takes place online. If the training, if the person has any challenges with internet accessibility, with broadband issues, if they have a concern about being able to sit in front of a computer for a certain number of hours, et cetera, you're going to lose some people as well. So just thinking about what are the training modalities and the accessibility needs that are relevant to that. And I think this is usually intuitive, and yet we often see that the training isn't always entirely relevant to the job. We're seeing a fair number of kind of prepackaged trainings where people just share what's been shared for years or what other people are sharing, and then the worker realizes once they start the job that they're actually not equipped for the role because the training wasn't tailored enough for the occupation. So just making sure that that's a piece of it. The second is making sure that the content covers a range of both relational and technical skills associated with quality care. Relational is unfortunately what some people call as soft skills, and they're not soft skills. They're communication skills that are central to whether a worker can succeed. For example, are they able to communicate to a client why they need to, be lifted in a certain way, right? Communication skills is really important. Do they have problem-solving skills? Too often, a worker is not just managing the relationship with the client, they're actually managing the relationship with the client and the family member. And if there are any problems that emerge, have the worker been trained in problem-solving skills. Those are all the relational skills that are important and so much more. Competency-based adult learner-centered instruction with opportunities for hands-on learning. Hands-on learning, it should be intuitive, but it's that the idea that it's especially in home care, it's really important that the worker have an opportunity to test the skills they're learning hands-on, because so much of this work is hands-on. Lifting, for example, as the most important piece. If a worker hasn't been trained properly for how to lift somebody, an accident can happen, and it can mean that the person who's being lifted is injured, but it can also mean that the worker is injured. In fact, direct care has some of the highest injury rates of any occupation in this country because so many people are being lifted at any given point. Also, opportunities that are learner-centered, again, didactic, might work for this group, but it doesn't often work for people who have limited English proficiency or people who have limited education. Competency-based is the idea that a training is being developed based on a set of core competencies. So not necessarily based on number of hours, but based on what are the core competencies that any worker should have before day one. So are they being trained on the essentials of what direct care entails? Are they being trained on relational skills, on how to communicate with family members, so much more, right? There are existing competency sets out there that a worker should be trained in, and the more that those training are based on that, the more successful you'll be. Workers often have cultural, linguistic, and learning differences. A learning difference might mean that they may not be great at taking a test, but a certain worker may be really great if it's experiential, right? Linguistic means that English might not be their primary language. Of course, they need to be able to speak English in many cases to take these roles, but there might be some barriers. So making sure that training is as simplified as possible in concepts and all of that. And cultural just simply accounts for the fact that there are cultural differences among workers as there are among clients. And so are you accounting for those differences? Documentation and verification of program completion is really important for the employer because you want to know that the worker you're hiring has been trained previously, and you want to make sure that the worker, if and when they move on, that their future employers also know that. But the more that you centralize the information, the easier it is for that person's employment. This is another quote from the guide that we produced a few years ago, which says that a living wage and better benefits are essential for recruiting and retaining, yet they're only one important piece of the puzzle that even when you're operating on tight margins, you can always show appreciation for your workers in a variety of ways, and workers will say that this makes a difference. So of course, from a quality job standpoint, a living wage is at least the minimum that a worker needs to be able to really survive, but also stay in these roles. I did mention earlier that it's become more and more about a competitive wage, which is often higher than a living wage. Now, many people on this call might be saying, well, you know, it's hard for us to operate financially on what we're being reimbursed for under Medicaid, for example, or just what it takes to run a business. And that's very true. And that's why near the end of this, I'll talk about some policy needs. But we do know just from taking a step back that a living wage is the bare minimum. Access to full-time hours is important. If you don't offer access to full-time hours, it means that workers often take second jobs, sometimes even third jobs, and that creates kind of a very tough scheduling approach. But that's the third pillar, that workers are notified ahead of time when a schedule changes and that their schedule can be as consistent as possible. For anyone who's a parent, and there are people on this call who I'm sure are, we know that a consistent schedule makes it easier to be a parent in today's world, right? It also makes it easier for a variety of reasons. And workers themselves will say that that kind of flexibility, when you can't offer higher wages, is sometimes the most important piece that you can offer, that I have more control over my schedule. By the way, there are new technologies that employers are using more and more to simplify scheduling, especially if you're a supervisor who's managing, say, 5 to 7 workers or much more than that. Having technology to really simplify that is important. In fact, we profiled an employer, I want to say in Maryland several years ago, that had pioneered a technology platform that simplified the scheduling. And there are many more, especially with artificial intelligence stepping in. Of course, making sure that there are benefit plans. If it's employer or if you're in a unionized environment, those are really critical. Otherwise, workers then access that health coverage on the exchanges and in the public mindset, or they go without health coverage, which can be really damaging for them financially. Because of COVID-19, but even long before, the kind of grief and emotional stress that many workers are dealing with has really amplified. And we see this not just in direct care workers, we see it among doctors, among nurses, among people who have been really on the front line of care for so many years, who are saying, like, the grief of that, I just can't take, and it's pushing them out of this sector. And yet what's different for direct care workers is that they often don't have either grief support or bereavement leave to help manage their mental health. In fact, if they're asked to pay out of pocket for, say, a therapist, oftentimes choosing between paying for a therapist or groceries, it's going to be an obvious answer what you choose. And so if an employer can offer that kind of mental health support, it can make a big difference. Financial support and asset development programs speak to the need for any of us, but especially if you're a low-wage worker, to plan for your financial future. That might be a year from now for a vacation or for an education and somebody in your family, or it can mean for your own retirement, right? But it takes a very specific kind of planning and calculus when you're a low-wage worker to be able to save. If you flash back to the slide that I shared earlier, it's often not near the top when it comes to how a worker spends their money. Also, access to merit, longevity, and other base pay increases. Maybe this is a one-time bonus. Maybe this is tied to a reward. So you're an employee of the month. Maybe it's a card or support with transportation. There are many ways in which this can happen, but it can make a real difference for a worker. Just a few examples from some employers who asked to remain anonymous. One employer offers a $120 bonus after completing 120 hours worked, and you can see the symmetry there, but it's meant to, of course, reward retention. There's also employee of the quarter with a $100 bonus, and this is just a way to really honor somebody who's been there. A $300 referral bonus. This is meant to draw on the networks of workers, their friends, their family members, but also to improve recruitment. And any kind of initiatives that help employees with government assistance programs, many of workers are accessing these, or community discounts, a membership to Costco or a local program, anything like that. More non-traditional benefits, some employers are allowing employees to determine the payment frequency and the timing. This can make a big difference for many workers. Offering non-traditional benefits like childcare, elder care, gas card, bus passes if you live in an area with transportation supports, membership to professional associations for workers who are wanting to build their healthcare or their professional career. And of course, I mentioned grief and mental health support, especially if it's affordable. Excuse me. A second area is quality supervision and support. Oftentimes in surveys of direct care workers, when you ask them what are the top reasons that they're leaving these jobs, they will cite low wages as one of them, but they often cite inadequate supervision as a second. And here I would say that there are a few different elements, what PHI would say. One is that making sure that job requirements, responsibilities, workflows, and reporting structures are really, really clear. We heard during the COVID-19 pandemic when we did research that many workers didn't even know who their supervisor was, much less what they needed to do day to day, week to week, etc. What was in their purview, what was not, who had final say on everything, and basically how the whole shop was operating. And so making sure that that's as clear as possible, I think, is an important piece. Supervision, of course, should be consistent, meaning that a person knows who that person is and that it stays day to day, week to week, month to month, accessible, that if somebody has a question, especially in the moment, or if you're in the field or on the floor, that you know exactly who to turn to, and especially during an emergency, of course, and that it's supportive. So too often supervision is punitive. So somebody does something wrong and then they get punished, versus a supportive supervision approach. And I'll talk about a resource that we have in that regard, where a worker knows that they can make mistakes and that they can learn along the way. All of us want that, I think, regardless of our occupations or at what level we operate. And it's especially important in a job of this level. Access to personal protective equipment, that was really critical during the height of COVID-19, but it's also critical in other instances. And so having those supplies available that ensures the worker and the client remain safe. Connection to peer mentors and peer support networks. This is especially important in the first few months of work. In fact, we have worked with employers to develop an advanced role to be a peer mentor. So if you're a worker and it's your first few months on the job and you're either on the floor or you're in the field, those few months can be scary. And sometimes even through the training, you realize within the first 24 hours of the first week that you don't actually know what to do step by step, right? That could be true, by the way, of any job. But a peer mentor can be somebody that's just like them. It's somebody that they work with, who they know they can run to before they go to a supervisor. And that person can coach them day to day, hour to hour, to really make sure they get the information they need. Connection to community-based organizations that can address the kinds of barriers that employees might be facing. So sometimes we see that employers forge relationships with, say, companies or agencies that can help with immigration questions or transportation needs or childcare, right? Oftentimes, even if you forge the relationship, there's still a cost, but the extent to which when those needs emerge among a worker, having somebody that you can refer them to can really make a big difference. And I think those people, those entities are often looking for those supports as well. We recently worked with AHCA and CAL to develop an e-learning module related to coaching supervision. And if you are a member of the American Healthcare Association and you want access to this e-learning, it's free to you. So you can actually go online, you can take a 4-hour training if you're a supervisor, and you can learn what does it mean to be a coaching supervisor. In other words, a supervisor that instead of punishing a worker who hasn't succeeded is somebody who can really tease out the reasons for that lack of success and then coach them through the ways forward. It's available to all AHCA and CAL members. And for those of you who are not, we are available as an organization to partner with you on the right approach. I want to pause with this quote from Erica Honan, who is a home care worker in San Francisco, California. She said, quote, "I think isolation in general is a challenge for caregivers, but with the risk of COVID added, it has really been very taxing. I'd say that's the hardest part of the job for me." Many workers will say this regardless of their occupation, regardless of their setting, and regardless of before, during, or after COVID, which is that it can feel really isolating. And you're making decisions that can be life-threatening for many people. And if you don't have the workflow or the supervisory knowledge, et cetera, to get through those decisions, it can really be scary. And so thinking about just that increased emotional duress in those moments is important. Respect and recognition is another pillar. And here we offer a few different elements. One, that direct care workers be reflected in the organizational mission, values, and business plans. For anybody in the organization, whether you're a manager, whether you're C-suite, whether you're somewhere else, seeing workers reflected in everything from the mission statement to the values to the day-to-day business strategies is really critical. It keeps these workers top of mind, and it makes you think, how does any strategy I implement impact these frontline workers? Of course, if the worker ever sees those documents, and many do, it's reassuring then to see yourself reflected in the ethos and the day-to-day practice of the organization. Diversity, equity, and inclusion are, of course, important. I think many people can speak to this. This is already, in many ways, a very diverse workforce. It's primarily made up of women, of people of color, of immigrants, and of older adults. And so making sure that there are measures in place to make sure that those populations feel valuable, that they feel like they're being included in decisions, and that the organization is thinking about how do you remove all the life barriers that many of these workers are facing? So, for example, if you're a woman and you're more likely to be taking on caregiving responsibility, which unfortunately this is what many women in the workforce are facing, are you offering good caregiving, childcare, and elder care supports? There are other examples as well. Consistent feedback is always important. In other words, not just when a mistake is made or when somebody succeeds, and that when retention is celebrated. And I'll share a few examples how people do that. Too often, direct care workers, even though they are on the front line of care for so many people, they're not consulted when it comes to organizational decisions. And so they will say, like, I don't understand why this policy or this protocol was put in place because it's not how I see the work. And it's frustrating that somebody, in management has made this decision, but they haven't consulted me. And so making sure that those voices, those experiences, and those needs are being integrated as decisions are being made is important. And this can be a feedback survey, this can be a focus group, this can be a number of ways in which those workers can be integrated. Making sure that any communication about a job is clearly communicated to a workers and that a worker has opportunity for feedback. That's key. Again, we saw during COVID-19 in the first 6 months, 6 to 12 months, that so many changes were being made, often by the day, by the week, just given the gravity of that situation. And yet workers weren't being consulted. So they'd say, hey, today I was told that I needed to do this. The next day I need to be told that I need to do that. I can't tell, is it the employer? Is it the state? Is it the federal government? Who's making these decisions? And many workers, by the way, were finding information not from their employers. They were finding it online. So they would jump online, on social media, etc. And that's confusing. It's also dangerous. Like, somebody should really be clear where the information should be coming from. And it should be a two-way street in many ways. Making sure that workers are empowered to participate in care planning and coordination. When we train workers and we work with employers to train workers on what care looks like, how to integrate them in advanced roles, etc. We don't just train the workers, we often train the supervisors and the executives. And one of the key areas that we train them on is how to value workers. Like, what are the ways in which, we can really let a worker know that their opinion is important, that, they are a big part of the organization, etc. And so again, making sure that there are clear ways in which they're empowered in that care coordination and that other workers see them as valuable and see their input and their skills. Marisol Rivera is a worker in the Bronx, New York, and she said, I think the role of the home health aide should be considered just as important as any other healthcare role. When we study the media, when we look at who are the healthcare workers that are being talked about, we see workers like in professionals like doctors, nurses, we see, physical therapists and so many others, but we don't often see direct care workers. Now, all of those other roles are incredibly important, but when a direct care worker sees that they're not being included in those narratives and those policy discussions, they're going to feel it, and that contributes to the extent to which they stay in these roles. One organization developed a peer mentor program. So this is an advanced role where a worker is trained to be a peer mentor. In other words, they are trained to support other new workers in the first 90 days of their employment so that those other workers can succeed. But the peer mentor also sees an advancement. They see a career ladder where they are able to make more money, they are able to learn new skills, etc. And they don't have to leave direct care in order to have that advancement. They also have a lead caregivers and mentor program. This is just another way of reframing it. They provide added support and training, and they're working side by side with the workers in the field. Public recognition is really important. We see more and more people appreciating workers in newsletters and other materials that are going out. Again, Caregiver of the Month awards, Employee Appreciation Day, etc. Those can actually, they might seem cosmetic or as some kind of signaling without any real change, but in fact, it can make a really big difference in terms of how these workers are supported, especially if there's a financial reward as well. Another pillar is real opportunity, and here there are a few dimensions. One is that the employer is offering continuous learning to build the core and the specialized direct care skills. So even if you're a worker who's already been trained at the entry level in your first 1 to 2 weeks of employment, you're going to need refreshers, you're going to need booster sessions, you're going to need to stay on top of the core skills that you need as a worker. And you're going to need specialized skills. You're going to need skill and training in how to support people with dementia or cardiovascular disease. Or maybe there are needs that if you're an LGBT consumer, you need, or an immigrant, you need, right? What are all those core and specialized skills that you need? The more you embed that in your training program and make it continuous, the stronger your program is going to be, and the better off your worker and your consumers or clients and residents are going to be. Also, that there are opportunities for promotion into advanced roles. Again, this doesn't necessarily require a change in scope of practice. You don't have to become a nurse or a doctor. You also don't have to become management or administrative, although those are relevant as well. You might create a dementia specialist who is able to support people living with dementia, and that's a growing population. And you make not just, say, a certain wage, but you make a bit more because you are taking on additional skills. Or maybe you're a peer mentor, or maybe you're a transition specialist, somebody who helps somebody coming from home enter a rehab center or come back home, and what are all the ways in which they remain responsible for those outcomes and those successes. Making sure there's always a commitment to cross-train workers and promote from within first. It can be really emotionally devastating when you're a worker who has been in a job for, say, 5 years, 10 years, etc., and you learn about a new opportunity on a job board outside the organization, right? Now, it might be that the employer has made, the decision that internally there is no one available, and so you want to go external. But a lot of times we find that that's usually just a mistake, that in fact, people didn't look inward first and then posted the job externally secondarily. And so you don't want a worker finding out of a job extra, and you want to be able to cultivate that candidacy within first. And then, of course, connections to external training and job development programs for other healthcare and social service careers. There will be a percentage of workers who see direct care as a rung in the ladder for a bigger healthcare career. So maybe they want to be doctors, maybe they want to be LPNs, maybe they just want to learn, and that requires education at a community college or maybe even a four-year university. There should be some connection between your setting and those settings so that you can facilitate that mobility and that portability across different settings. This is again a quote from a guide that we released a few years ago. It said the key to retaining a committed and well-qualified direct care workforce is to recruit the right individuals from the start, those who are most likely to succeed in the caregiving role. I focused mostly on efforts that are about retaining workers and making sure that the jobs are as strong as possible. But of course, there are a lot of recruitment needs that can make a big difference. Increasingly, we are seeing more and more people recruit successfully through social media, through their own phones, online, etc. We see efforts through job fairs where oftentimes people are looking for multiple jobs, accessing people's personal networks, their families, their friends, making sure that we're capitalizing on that. And increasingly, I think with the advent of AI or artificial intelligence, there are probably ways in which you can use programs like ChatGPT and other new programs to come up with the best ways to reach people, the right language, and all of that. Are you also recruiting populations that are underrepresented? Are you recruiting men? Are you recruiting people 55 and older? Like all of those are labor pools that could be really relevant in these jobs, but they probably require certain methods, right? Older people might already be emotionally connected to the job because they were family caregivers. Many of them were, right? But they might want more flexibility because they're in the later stages of their career and they're thinking about something that's rewarding but also more flexible. And there's lots of good examples that could be drawn from that. I want to offer just three areas that, three questions that you might consider asking yourself as you create jobs for workers. Do you have a dedicated budget for retention practices and for innovations? Or are you having to draw from the bare minimum that is left over at any given month or in every given year. The more you dedicate a budget for these kinds of practices and for trying things out differently, the more successful you'll be. We've seen, for example, some states have developed what they call innovation funds. So this is a policy measure. It's a government fund that the state will adopt that says we have, $1 million to $5 million a year that we're only going to dedicate for retention and for innovation. And we're going to require that anybody who innovates, that they're also evaluating. So was the program successful? Where was it not? Did we do any harm? Hopefully not, but hopefully you're evaluating for that. And then those that are successful, we're going to replicate them at a wide scale. And so I would encourage you, even at the local level or at the employer level, to dedicate a budget to innovation, to retention, and to evaluation. What does your data look like? Are you collecting data not just on full-time and part-time employees or vacancy rates or all of that, but are you collecting data on what are workers saying, the reasons they're leaving these jobs or the reasons that they're taking these jobs, or what are the factors that would compel them to leave? Like, those are all really important data points that can be surveyed to just understand what workers and what they want. If you feel like you don't have enough men in your direct care workforce, are you surveying men in particular, both those who are employed in your jobs and those who are not, to understand what would compel them to take these jobs? Like, there are lots of ways in which you can use data to understand that. And then also looking at your recruitment practices. Again, this is about evaluation. Are your recruitment practices also impacting retention? We often say when we work with employers, hire for character, but train for skill, meaning that you should be screening very closely the type of candidate that you are hiring for these workers. Otherwise, even the best training and onboarding approach isn't going to keep them within 6 months. And so what does your screener look like? What are the questions you're asking? And are you seeing a correlation between a high recruitment rate and a high retention rate? Or are you seeing the opposite? Are you seeing that recruitment is at a much higher rate than, say, retention? Well, that's telling you you're probably not hiring the right person, or the first 60 to 90 months are not as strong as possible. I want to end with just a few policy examples. Now, even though this is not necessarily a policy audience, what we often find is that they're interrelated, of course, right? So the kinds of requirements that providers have, the amount of funding and reimbursement rates that employers have, and sometimes employers are playing a role in the government process and are influencing the extent to which the policies and the funding are shaping this workforce. So I just want to share 5 quick examples. One is that we saw, for example, in Washington State, a comprehensive approach to training and certified home care workers. So what we see as a problem in every state around the country, most states, is that if you're trained and certified in one employment setting or in one setting in particular, that it's not transferable or portable to other settings. And so what it means is if you're trained as a home care worker at employer A, you move to employer B, that employer has to retrain the worker all over again. And it's unclear the extent to which those trainings are rooted in the latest core competencies. Well, Washington State said, well, let's universalize this, right? Let's make the home care aid training and certification one thing. Let's make it portable so that if you're trained in one setting and you move to the next, then, an employer doesn't have to retrain them and the worker doesn't have to undergo pretty much the same training, right? So to the extent that this can be a policy need or it starts as a market need first, this can be really important. This is actually Arizona. Many of you are probably familiar with Mercy Care, which is a managed care organization. They recently awarded, I think they established a $1 million innovation fund that allowed their providers to basically test a wide range of innovations related to things like career advancement or recruitment and so much more. This can also be done at the provider level, right? You could innovate in your own way and again, test, evaluate, et cetera, but it's much better when the amount is larger. And so that's a policy question. How can the state of Arizona, how can any state begin testing innovations that help people recruit and retain? Matching service registries are really critical. These are online job portals where a consumer, typically in a consumer-directed program, can find a worker and vice vice versa, and they can find each other based on their preferences, their needs, and their availability. If the Arizona or others were to develop a very strong matching service registry, probably starting in the consumer directed program, but could be broader, to help people find each other and make sure that this portal abides by the best technologies out there, meaning that it should be a public-private venture. This can make a big difference to making sure that consumers are aligned with the best workers and vice versa. The final example I'll offer is in Texas. We worked with their Department of Health to improve reporting requirements and to better study direct care workers across their state. And of course, just given how scattered the system is, they started with a small slice of the workforce, but they required essentially providers to submit data on the size, stability, and compensation of their employees in a specific segment of the workforce. That data then allows the state to assess, like, where are there gaps, where could the workforce be better stabilized, and what can we do in the future to better understand who these workers are, et cetera. Again, this is a policy question, although it starts at the provider level, making sure that you're collecting the proper data. I also want to say that did I skip one? I'm sorry, in Wisconsin, yes. This is one of our favorite examples, which is that Wisconsin several years ago created a program called WIS Caregiver Careers. And it started as a training and recruitment program for nursing assistants. And so they basically developed a program and a very ambitious goal to train and recruit thousands of nursing assistants in their states. And they were successful. They ran digital recruitment programs. They offered people incentives to become workers. And then they trained and certified them based on one curricula. They have since expanded that to home care, and they are creating what you might call kind of a universal worker approach, so that if you're trained as a nursing assistant or as a home health aide, that you can then automatically work in each of those settings, and not necessarily be retrained or recertified. And you have this kind of really impressive credential that you can carry across the state. And it's meant to make the job more appealing and less devalued, but also to make it easier for employers to hire workers. If Wisconsin were to then convince a neighboring state like Michigan to adopt an interstate training agreement, then it means those workers can work from one state to the next. And that's the ideal, right? We should get to a point where if you're trained in any state in this country, that you can work across all states, and it would do quite a bit for the sector. I do want to say that earlier this year, we released the Direct Care Workforce State Index, which measures and ranks all 50 states plus DC in terms of the kinds of policies they have implemented to support these workers, and then how those workers are faring financially. And Arizona ranks 21, which is impressive. So I would encourage people, when they have a moment, probably not during the call, but afterward, to visit that index on our site, and you can see the kinds of policies that are available. Now, it's impressive relative to what other states are doing. So rarely are states doing enough for these workers, but 21 is, higher than the median. I'll end you with this quote, which is Michelle Godwin, who is a nursing assistant in Florida. She said, "If I could make a change, it would be for this field to show more appreciation for what we do, because we are the main backbone of this work." I would say, together with family caregivers, they are the front line of daily support for so many direct care workers, and yet we don't show them enough appreciation in real ways. I think some of us do in our employment settings or as individuals, but if we did show them appreciation, I think we wouldn't see the workforce shortage that we're seeing these days. Thank you for listening to my presentation. I'm going to stop sharing so that we can all look at each other and so that I can answer any questions that people might have. Thank you.
Thank you very much, Robert. That was a lot of information and very important information, and we appreciate you sharing it with us. I didn't see any questions in the chat. Does anybody have any questions? Linda, if you could unmute people and they could just chime in if they have any questions.
Okay, if everybody will just unmute themselves, that'll work. I can't go in and unmute globally.
Okay. Okay.
I do have a question, Robert. Over and over and over again, I keep hearing non-skilled labor. Now, we are about 50% home health and 50% non-medical. And my feeling is, particularly after everything you've just said regarding training, there is no such thing as non-skilled labor. What can we do to change this misnomer about, as far as I'm concerned, you call one of your workers non-skilled, and that's like a slap on the face, and it's no wonder they quit.
Yeah, absolutely. It's one of the greatest misconceptions in the sector that it's either unskilled or low skilled, when in fact, everything that we know is that it requires an incredible amount of skill and knowledge, especially if you're a home health aide or nursing assistant, which does the clinical work. And it requires physical and emotional labor. I mean, these workers are doing miracles, I think, in people's homes, in assisted living, and in nursing homes. So I do think it's a great misrepresentation. I mean, one of the strategies that we're seeing states and employers take on are public education campaigns. So in addition to everything that they're doing, they're putting some dollars and creative thinking into educating people on who are these workers, what are their roles and responsibilities, what are some of the greatest myths, like the myth of low skilled and unskilled labor, and what can we do, whether you're an individual or an employer or a policymaker, what can we do to improve these jobs and make sure that all of us get the care that we deserve? It is a huge myth, and it harms all of us.
Thank you
Thanks
very
for
much.
that. Yeah, that helped a lot. But you're going to be speaking at our conference, so any possibility you can kind of throw that in someplace?
Yeah, absolutely. And I can share some really great examples of what others have done. Yep, thank you.
Perfect.
Okay, do we have any other questions?
We have one from Rebecca McGee.
Hi. So, thank you for coming to speak to us. One of the things that we have talked about a lot, I think, as an industry, and that I think as an agency, I'm from Pima Council on Aging, and we serve older adults in that aspect, and we also have a home care company, and we have a training program. And so one of the things that has been a conversation in the industry for quite a while is talking about career path development for entry-level healthcare workers. And I think that's great. And at having a training program, I would think that was great. I mean, we're moving folks from being direct care workers to certified caregivers to CNAs and looking at other paths in the industry. But I also recognize that is not the path for the majority of the folks that we have coming into our workforce. And I feel like we leave a lot on the table in terms of talking about opportunity for this workforce when we focus simply on that ladder, that it has to be that ladder that folks are climbing if they're coming in the door as a direct care worker. And for many of them, that is not their goal. This is an opportunity for them to get into either the caring industry or the healthcare industry in some aspect, but it's not that ladder. Can you talk, and I know that PHI has done some work about that and had some more conversations about that nationally. Can you talk a little bit about that shift in mindset and conversation and what that looks like?
Yeah, absolutely. I mean, I think you covered a lot of the key points, which is that not only is it not their choice, but it's also not a viable path. It's not financially affordable. It's just not what's within their scope of their career, right? And too often, and it's also a little bit idealized, right? We want to see all of a sudden every direct care worker become a doctor or nurse. That's not going to happen, right? And if that were to happen, well, then we would have a major workforce shortage. So what we say often is that there are a number of ways that employers can create advanced roles within direct care that don't take workers out of direct care. So I'm going to put in the chat one of them, which is this is a role that we created at PHI. It's called the Care Integration Senior Aide, and it's for a home care worker who, you know, is interested in advancement. They're trained to become a senior aide, and what they do is they help monitor changes in client condition, and then they're plugged into the care team, the interdisciplinary care team, and they're made sure. And so if a doctor or somebody else has a question about you know, a change in a client condition, or if the worker observes it, they are able to share that information and kind of work with that person. And so, you know, the guide offers a closer sense of what that role would entail. It also suggests that to implement a program like that, you're not just training the worker, you're training the other staff to value the worker and how to work with them, et cetera. And that's a great example. I mean, we've also seen employers develop transition dementia specialists, just given the high rates of dementia. And these are people who are trained in dementia care. And then again, they're still supporting people as direct care workers, but on top of that, they're specialized in dementia. And then the other piece is the peer mentor, and that's, I mentioned it earlier, which is helping people in the field. And there are many other roles that don't require, you know, significant education credentials. It doesn't require a lot of money for the worker. It just requires thinking, and it requires an investment in some elevated compensation, of course, and titles. But it means that the job can actually be a career, not just a paycheck.
I know that in other states, thank you, that's very helpful. I think just understanding the internal structure of what that looks like. I know in other states, and you guys have done a fair amount of work with Arizona, especially in the last few years. And we've had conversations with you around advocacy, but I think looking at creating a pay structure that also supports that from a state level, is that something that you and your team are willing to have? And I know that's I know part of that's on the other side of your PHI house, but is that a conversation that you're willing to engage in about advocating for a structure that also supports that? So when you're getting referrals from clients in a state-based program, that there are allowances for providing additional support in a pay structure so that you have direct care staff that are equipped with those skills and compensated for those skills to go into that structure.
Yeah, absolutely. I mean, it is within our advocacy recommendations, which is that too often, I mean, in general, there's not enough Medicaid funding and there's not enough reimbursement rates, right? But and if there's not enough funding for wages, there's even less for training, advanced roles, other kinds of job equality improvements, right? And so absolutely. I mean, and I think that, you know, you're hitting on a bigger systemic problem, which is that we have reached a point where we need to rethink our financing system in this country, because just given the numbers and given how strained many states are, it's going to be hard to really transform these jobs unless we think about more money. Yeah.
Yeah. Oh, I'll just mute myself now.
Thank you. Those are great.
Thank you for your questions. That's great. It just provides more information from Robert with so much knowledge in this industry. Thank you very much again. I don't believe I see any other questions, so I think we'll go towards the end of our meeting. The Osnaha Board of Directors want to thank you all for participating today. Our July session will be Wednesday, July 20th. Oh, do you have a question, Bob Roth? Now you're on mute.
I wanted to say thank you, Robert. I wanted to say thank you, Laurel, and to the board. Great presentation, really some good information. So I want to thank you.
Thank you very much. So our July education will be Wednesday, July 20th, and our speakers will be Charles Scott and Sherry Nordstrom Scott with Peloton Financial Management, and their topic will be 5 parts of financial planning with a focus on the senior market. So watch for advertising for this session coming soon via MailChimp. Please make sure you RSVP. Thank you, everyone, and have a great afternoon.